Ready.
Okay, good afternoon, everyone. Today is Monday, October 18th, 2021. We have convened the Board of Health for the New York City Department of Health and Mental Hygiene. It is 3:05 p.m. and I will call this meeting to order. Before we commence with the roll call, allow me to welcome our two newest board members to their first convening of the Board of Health. First is Dr. Sidney Hankerson, who holds an ex officio seat as the chair of the Community Service Board. Dr. Hankerson is co-director of the Columbia Wellness Center, associate professor of psychiatry at Columbia University Irving Medical Center, and an adult psychiatrist at the New York Presbyterian Charles B. Rangel Community Health Center. His research focuses on reducing racial and ethnic disparities in mental health treatment and has received numerous grant funding, including from the National Institute of Mental Health. He is also a nationally recognized expert at faith-based mental health services research. Dr. Hankerson completed a dual MD-MBA program from Emory University and postdoctoral research fellowship at Columbia, New York State Psychiatric Institute. I want to extend such a warm welcome to Dr. Hankerson. I'm really excited that you're joining the board and bringing your expertise to bear for the benefit of New Yorkers. Our next new board member is Dr. Simona Kwan. Dr. Kwan is an associate professor and vice chair for diversity, equity, and inclusion in the Department of Population Health at NYU Grossman School of Medicine. She also serves as the director of the NIH National Institute on Minority Health and Health Disparities funded Center of Excellence, the NYU Center for the Study of Asian American Health. Dr. Kwan is a social behavioral epidemiologist whose research has focused on social and cultural factors that influence health and health outcomes in racial, ethnic, and immigrant communities, with a core focus on advancing health equity in research, policy, and practice. Dr. Kwan received her MPH from Yale University, doctorate in public health from Columbia, and completed postdoctoral training at Johns Hopkins University Bloomberg School of Public Health. Likewise, Dr. Kwan, I'm so delighted to be able to welcome you to the Board of Health this afternoon. Thank you both. And now I will conduct the roll call. I'll say your name and please respond with here or yes. Dr. Joel Foreman.
Here.
Dr. Sidney Hankerson.
Here, and thank you, Commissioner, for that warm introduction.
Welcome. Karen Redliner.
Here.
Dr. Lynn Richardson.
Here.
Pamela Breyer.
Here.
Dr. Mitchell Katz. Is Dr. Katz here? We'll circle back around. Dr. Simona Kwan.
Here.
Rosa Gill. I don't believe Rosa Gill is going to be able to join us.
You won't.
Dr. Sixto Caro.
Here.
And Dr. Susan Klitzman.
Here.
Thank you so much. Before we discuss the items on today's agenda, let's start with approval of the minutes from the September 17th meeting. Actually, before we start, I believe I see Dr. Katz joining. Let's give him a moment just to complete the roll call. Dr. Katz, are you able to hear us?
Yes, can you hear me?
Yes, we were just finishing roll call, so thank you.
Okay, thank you.
Great, so let's turn to the review and approval of the minutes from September 17th, 2021. Are there any corrections to the minutes from the September 17th meeting? Okay, I see Dr. Foreman shaking his head. So
So I'll move to approve the minutes as they are written.
Wonderful.
Second.
Thank you for the motion. And I
Second.
heard a second from Dr. Richardson. Thank you so much. All those in favor?
Aye.
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 Thank you. Any opposed? Okay, hearing none, the minutes from the September 17th meeting are approved as distributed. Okay, my fellow board members, as your chair, it's genuinely my privilege to introduce our first agenda item, a resolution on racism as a public health crisis. I wish to start by invoking the history of the New York City Board of Health. As many of you know, the board was originally forged in the crucible of epidemic response, yellow fever, cholera, and smallpox. The scientific links between the environment and public health became irrefutable, and advances in sanitation saved countless lives, particularly those of poor and immigrant New Yorkers. Now we are in another crucible, another pandemic in which suffering is not borne equally. We recently marked 700,000 deaths from COVID-19 in the United States. But even that devastating overall toll belies that Black, Indigenous, and people of color are all at least twice as likely to die compared to white people. And even focusing solely on mortality obscures other reverberating effects on public health. A health department analysis found that last year, Black and Latino New Yorkers were 1.3 to 2 times more likely than white New Yorkers to report being unable to pay rent, phone or internet bills, and afford groceries. These numbers demonstrate the catastrophic combustibility of historical patterns of injustice, particularly structural racism, intersecting with disease. As the saying goes, history doesn't repeat itself, but it often rhymes. In 1865, our forebears on the Board of Health wrote, "We believe that housing, politics, morals, and health are all intertwined." They are indeed, and the data bears this out. Just as our predecessors moved beyond a superficial understanding of the links between the physical environment and health, like the miasma theory of disease, we must further confront how the social environment shapes health and illness. For instance, to elucidate the root causes of racial inequities during COVID-19, we must ask ourselves a succession of why questions. Why do some non-white populations develop severe disease and die from COVID-19 at higher rates than whites? Underlying health conditions undoubtedly play a role, but why are there higher rates of hypertension, diabetes, and obesity in communities of color? The answer does not lie in biology. Structural and environmental factors such as disinvestment, discrimination, and disinformation underlie a greater burden of these diseases in communities of color. The most significant why may be, why are these widespread inequities allowed to persist? We must keep in mind that inequities are disparities that are avoidable, unjust, and unfair. Racism, as my colleagues will describe further, negatively affects the mental and physical health of our family members, neighbors, and colleagues. Importantly, racism exacts a health and economic cost on all of society, what the scholar Heather McGee encapsulates as, "We are greater than and greater for the sum of us." We are greater than and greater for the sum of us. We are therefore at a pivotal moment in taking on racism as a public health crisis. And the COVID-19 pandemic must render unacceptable that which has been condoned for generations. We have chosen our words carefully this afternoon in presenting this to you as a resolution rather than just a declaration, because we must be resolute, because we must resolve to take action beyond our recognition of the problem. With that prelude, I am pleased to turn the floor over to Dr. Torian Easterling, First Deputy Commissioner and Chief Equity Officer of DOHMH, and Dr. Michelle Morse, Deputy Commissioner and Chief Medical Officer. Thank you.
Thank you, Commissioner. It is a pleasure to be joining all of you this afternoon. As the Commissioner has already mentioned, my name is Dr. Torian Easterling. I have the honor of serving as the first Deputy Commissioner and Chief Equity Officer for the New York City Department of Health. Also, as the Commissioner has mentioned, racism is harming the health of Black and Brown New Yorkers due to persistent systemic and intergenerational systems of oppression. But I also want to make sure that we do note here up front that this oppression is also amplified by individuals holding multiple intersecting identities, including LGBTQ+, people of color, and women of color. And so it is really important as we move forward that as part of this resolution, that we are putting racial equity at the core of all of our city processes, advocating for the policies that we know can and will improve the health of all New Yorkers, and specifically those who are most marginalized and feel the weight of this oppression. And so I am honored again to be joining you all this afternoon and look forward to the discussion. I will turn it over to my colleague, Dr. Morse, to also introduce herself.
Thank you so much, Commissioner. Thank you, Dr. Easterling, and good afternoon to all the Board of Health members. It's a real honor to get to be with you this afternoon for this really exciting moment. My name is Dr. Michelle Morse. I am the Deputy Commissioner for our Center for Health Equity and Community Wellness at the Health Department, and I'm also the agency's inaugural Chief Medical Officer. I'm an internist by training, and again, very honored to be with you. And appreciate all of the work and comments and really exciting opportunity we have to institutionalize our work in anti-racism in partnership with all of you.
Great, so we will now move forward. What we wanted to do first was to walk through the preamble of the resolution. So Dr. Morse and I will read through the whereas clauses as we move forward in our presentation. So with that, beginning with whereas the mission of the New York City Department of Health and Mental Hygiene is to protect and promote the health of all New Yorkers, and its vision is a city where all New Yorkers can realize their full health potential, regardless of who they are, where they are from, or where they live. And whereas there is a long history of structural racism impacting services and care across all institutions within our society. And whereas Black, Indigenous, and people of color, New Yorkers have suffered from disproportionately high rates of COVID-19 infection and death, including a disproportionate drop in life expectancy for Black and Latino New Yorkers. And Black and Latino New Yorkers have disproportionately low rates of COVID-19 vaccination. And whereas the New York City Health Department has extensively documented racial inequities in rates of HIV, tuberculosis, maternal mortality, infant mortality, mental health conditions, chronic disease prevalence and mortality, gun violence, and other forms of physical violence, premature mortality, among others that existed prior to the COVID-19 pandemic. Next slide.
Whereas our country has a long history of anti-Asian violence, including the Page Exclusion Act, the Chinese Exclusion Act, and Japanese internment, which created some of the conditions for current rising anti-Asian discrimination. And whereas involvement with law enforcement has grown markedly in the US in recent decades, and studies have shown these interactions are associated with poor health outcomes, including injuries and fatalities. And whereas New York City's investments have reduced the jail population and reformed law enforcement practices in communities, and whereas structural racism systematically excludes, marginalizes, and harms BIPOC across New York City through discriminatory housing, employment, education, healthcare, criminal, legal, and other systems, all of which results in avoidable and unjust health outcomes, also known as health inequities. Next slide.
Whereas New York City aims to address structural racism and longstanding inequities and seeks to build upon existing efforts, such as the annual Social Indicators Report and standard equity metrics created by Executive Order number 45, dated May 8, 2019. and the establishment of the city's task force on racial inclusion and equity, created by Executive Order number 80, dated September 13, 2021, to address the disparate impact of COVID-19 in BIPOC communities. And whereas the first declaration of racism as a public health crisis was developed in 2018 by a Black woman, Ms. Lillian Payne, while she was Director at Large of the Wisconsin Public Health Association, and more than 200 similar declarations have been made across the country since, including from the Center for Disease Control and Prevention. And whereas in 2016, the New York City Health Department launched Race to Justice to build the health department's capacity to address structural racism and health inequities, and has committed to uprooting white supremacy and its impact on health and well-being, while shifting resources and power to the communities that bear the greatest burden of marginalization, racism, and health inequities. And
whereas the New York City Health Department initially declared racism a public health crisis on June 8, 2020, and now seeks to expand on this declaration through direct actions across the health department. And whereas Take Care New York is a comprehensive health plan for New York City that lays out the health department's priorities to advance anti-racism public health practice, reduce health inequities, and strengthen New York City's collective approach to ensuring that all New Yorkers can realize their full health potential, regardless of who they are, where they are from, or where they live. And whereas settler colonialism, indigenous genocide, and enslavement of Africans are part of the history of our nation, and whereas the city of New York is situated on Lenape, Rockaway, and Canarsie land. Next slide.
whereas these original injustices have been without comprehensive restitution or redress, and whereas race is a social and political construct based on the social interpretation of how one's identity is perceived with no biological or genetic basis. And whereas racism is a system of structuring opportunity and assigning value based on how one's appearance is perceived, which unfairly advantages some individuals and communities, unfairly disadvantages other individuals and communities, and saps the strength of the whole society. And whereas racism is a race-explicit system, and anti-racism requires race-explicit strategies. And whereas BIPOC-led organizations and communities have been fighting racism for generations and making sacrifices to ensure progress toward a racially just future. Next slide.
Whereas intersectionality, which acknowledges the unique impact and experience of oppression when a person or community holds multiple marginalized identities, is a critical strategy to fight the public health crisis of racism, is a central tenet of critical race theory, and is a key framework for data analysis. And whereas the crisis of racism in this country is long-standing and our nation's response will need to span generations, and whereas the work of undoing racism is grounded in love as well as science and civic duty, this love is not sentimental, rather it is what James Baldwin called the tough and universal sense of quest and daring and growth.
Thank you. So we wanted to make sure to take the time to walk through the preamble whereas clauses to ensure that we laid the groundwork for why this is a historic moment, but also as we're moving from declaration to resolution. But to that point, we do want to acknowledge that there has been a lot of work that this agency and the city has taken on, even to get to this point. And so some of that background, and just to provide briefly, just to raise at the level of city administration, through Executive Order 45, which was alluded and mentioned in the preamble, really has been led by Mayor's Office of Economic Opportunity. And as I mentioned, has ordered us annual social indicators report, which measures social, economic, environmental health of New York City. The agency has contributed to this report and has really allowed us to identify important areas that we can continue to improve upon our data collection processes, think about ways in which you can disaggregate our data around race ethnicity, and gender, as well as sexual orientation, and think about all the other practices that we can continue to improve upon. In addition, another investment that the city has made most recently is a task force on racial inclusion and equity, which is composed primarily of city agency leaders of color from over 65 different agencies, launched first in April 2020 to really work as an interdisciplinary team to address inequities around COVID-19 response. And it has been co-chaired by the First Lady of New York City, Charlene McCray, Deputy Mayor Phil Thompson, and Deputy Mayor Health and Human Services, Melanie Hartzog. The task force is also led by the Executive Director, Sadia Sherman, and has been really supportive of this process. Both the task force and now the Racial Justice Commission has been part of the mayor's Recovery for All to really think about how government really needs to bend to fight inequities. And I think this is really important as we continue to look forward and sort of really think about the direction, not only that the city is taking, but the agency as well. So as I mentioned, the Racial Justice Commission, which was established in March 2021, was really announced as a way in which can really think about different strategies to think about how we can make charter revisions and these abilities to propose changes on the New York City Charter. The commission is led by Jennifer Joan Alston, and the vice chair is Henry Garrido, and really focuses on racial justice and reconciliation. And then at the agency level, as some of the board members already know, in 2015, the agency did do a reframe around our annual strategic plan to think about ways in which we can not only name the injustices, but also to think about ways in which we address it. And so through our blueprint for New York City, Take Care New York, New York 2020, really being explicit about naming how we can address structural racism and leveraging the agency's resources. In addition, around that same time, we did, under the leadership of Dr. Bassett, did also make investments in how we structure our resources and the development of the Center for Health Equity, now the Center for Health Equity and Community Wellness, to think about how we're using our data, to think about how we are intentional and explicit about the resources at a place-based level, and the opportunities that we have to work and partner not only with city agencies, but also with our community-based organizations. And that work continues today. Also in 2016, the agency launched its Race to Justice internal transformation process, really looking at ways that we can name and have a shared analysis around injustice and structural racism, organize ourselves, and thinking about the ways in which we really embed our planning in the agency, but also operationalize this work to really meet and advance to our equitable outcomes. I wanted to provide that background again, just to ensure all of the board members were aware of some of the previous work. And now to look ahead on the next slide, as was already mentioned, the agency did declare racism as a public health crisis last year. And so in moving from declaration to resolution, this is the time in which we really are looking to commit those actions. But we're not just starting today. Some of those actions have already begun. And just to mention a few of them, we have done a lot of work to really think about how we apply an equity lens to our COVID-19 response, not only in slowing the spread of transmission, but also in supporting the greatest vaccination campaign, which is why we did launch an equity action plan, both for our COVID-19 response, as well as for our vaccination campaign. In addition, the investments that were made over the last year in supporting our community-based organizations to really leverage the expertise, to really leverage the footprint and catchment areas that they're really able to reach, and to make sure that we're partnering with these trusted messengers in our community, both through in partnership with health and hospitals, through test and trace community-based organizations, and through our vaccine equity partner engagement grant, really investing millions into our community-based organizations. And then we look forward to really thinking about how we expand and evolve on those investments and what is now known as the Public Health Corps, which the mayor has recently announced several weeks ago, really an anti-racist cadre of community health workers being out in the community and supporting resource navigation, intel gathering, and really coordinating with other organizations, not only both in the community, but also in clinical-based centers, as this is a unified approach for both the Department of Health and Mental Hygiene and New York City Health and Hospital. Next slide.
We want to also highlight that this phenomenon of declarations of racism as a public health crisis is a national and actually global phenomenon. In fact, the declaration was passed in Barcelona, Spain, not long ago as well. So this is truly a global phenomenon, but particularly in the United States, if you look at the original declaration, as was mentioned in the whereas statements by Lillian Payne, building on her work across the country with that original 2018 Wisconsin Public Health Association declaration, which was at the time really directly connected to Dr. Kamara Jones's as president of the American Public Health Association, her national campaign against racism as prior president. In addition, after the declaration from Wisconsin in 2018, as you see on the graph in the right, from the time of the murder of George Floyd in May of 2020, there was an exponential increase in the number of declarations that were made across the country. And now in 2021, we're at over 217 declarations across locales across this country. And again, the New York City Health Department, in partnership with this Board of Health, is really excited to be able to institutionalize this work, as was mentioned, in transitioning from declaration to resolution. Next slide.
So with that, we want to walk through the resolution and acknowledgements. And as such, we are asking the board to formally declare racism a public health crisis through passage of a resolution, including the following actions. One, to declare that racism is a public health crisis. Two, to acknowledge the work to date to address the health impacts of racism in New York City, including but not limited to launching Race to Justice and improving reporting of race and ethnicity data during COVID-19, and request that the department expand that work to develop priorities and next steps for racially just recovery from COVID-19 and other actions, including resource allocation to address this public health crisis in the short and long term. Next slide.
In addition, number 3 requests that the New York City Health Department research, clarify, and acknowledge examples of its historic role in divesting and underinvesting in critical community-led health programs, and participate in a truth and reconciliation process with communities harmed by these actions when possible. Number 4 requests that the New York City Health Department establish a Data for Equity working group to ensure the agency apply an intersectional anti-racism equity lens to public health data and provide annual guidance to other New York City mayoral agencies on best practices to collect and make available to the health department relevant data to track and improve health equity. And number 5 requests that the New York City Health Department make recommendations on anti-racism, health-related New York City charter revisions to the Mayoral Racial Justice Commission to strengthen New York City's effort to combat racism.
To continue, number 6, request that the New York City Health Department continue collaborations with sister agencies to report on fatalities, injuries, health conditions by race, gender, and other demographics to improve data quality and care. Number 7, request that the New York City Health Department, in consultation with relevant community organizations, perform an anti-racism review of the New York City Health Code to identify any existing provisions that support systemic and structural racism and bias, and recommend new provisions to dismantle systemic and structural racism and bias. And number 8, request that the New York City Health Department partner with city agencies and relevant organizations, consistent with Local Law 174, which is dated October 13th, 2019, in Executive Order number 45, dated May 8th, 2019, to advise on assessments of structural racism within policies, plans, and budgets related to all determinants of health, which includes transportation, education, housing, economic opportunities, civic participation, and healthcare delivery context, and make recommendations to mitigate harm within a public health context. Next slide.
And finally, number 9, requests that the New York City Health Department report twice per year to the Board of Health to promote the work associated with this resolution and to ensure the NYC Health Department is accountable on progress. Next slide.
With that, let's conclude our proposed actions. We do want to take the time to recognize some very key and critical stakeholders who were really instrumental in elevating the need to make this aspirational resolution concrete and actionable. And with that, I do want to acknowledge Dr. C. Virginia Fields, Guillermo Chacon, Charles King, Virginia Schubert, Mark Harrington, and Matthew Brinkenoff. And with that, next slide. We welcome the board for any questions or any comments. And we certainly would like to hear from everyone. Commissioner.
Thank you so much, Dr. Easterling and Dr. Morse. That was a powerful description of our resolution. At this time, I'd like to commence discussion among the board. I would actually like to break from protocol somewhat and give each board member the opportunity to make comments or pose a question. I'll go in reverse order of our roll call. And certainly no obligation to offer any comments or pose a question, but if you would like, then please try to limit it to about 2 minutes so we can get through everyone. So I'll start with Dr. Susan Klitzman.
Thank you, Dr. Chakshi, and thank you very much, Drs. Easterling and Dr. Morse, for a very compelling presentation and all the thought that went into this resolution and all the work of you and your staff. I guess I'll start by saying that the resolution is very comprehensive and really, to my mind, as someone who's been associated with the agency for more than 30 years, really represents the culmination of a lot of excellent and groundbreaking work and a long commitment to anti-racism. And I really like the approach. It's very comprehensive in terms of addressing the structural determinants of racism and its impact on health, but also in its very broad approach in terms of solutions, looking at data, looking at practices, looking at policies, both within the agency and public, and an allusion to private partnerships as well. My one comment and question really relates to point 8 in the preamble and point 8 in the resolution. And specifically, it talks about, let me just count 1, 2, 3, 4, 5, 6, 7, 8. Whereas structural racism systematically excludes, marginalizes, and harms BIPOC across NYC through discriminatory housing, employment, education, healthcare, criminal, legal, and other systems, all of which result in avoidable and unjust health outcomes, health inequities. And then in the resolution, the point that requests that the New York City Health Department partner with New York City agencies and relevant organizations to advise on assessments of structural racism within policies, plans, and budgets related to all determinants of health, transportation, education, housing, economic opportunity, civic participation, and healthcare delivery contexts, and make recommendations to mitigate harm within a public health context. I would like to suggest for the agency's consideration, adding something about land use and decisions about how facilities are sited, and also look at cumulative impacts within a community, both of the cumulative benefits and beneficial resources in that community, as well as the issues that detract from optimal health. And just as one example, I'm with the CUNY School of Public Health, and we're located in central Harlem at 125th Street. And just as an example, our neighborhood has a very disproportionate number of drug treatment centers, of facilities that serve the homeless. We are increasingly, since COVID, impacted by the syndemics of homelessness, drug addiction, and mental illness that is only exacerbated by COVID. And if you look at the distribution of mental health treatment and drug treatment facilities, there's a very disproportionate concentration in that neighborhood. And it's not clear to me that these facilities are either sited equitably through the entire city, or that resources are provided to really support people in need of mental health and addiction and related services. So again, just to summarize and give others a chance to speak, I'm suggesting for the agency's consideration to look at cumulative neighborhood impacts of facilities, and to also consider siting and land use decisions in its resolution. Thank you.
Thank you very much, Dr. Klitzman, and thank you for drawing that parallel between the eighth whereas clause as well as the eighth point in the actions in the resolution, and making that point about land use and siting, which I think certainly, the spirit of it is in the intent with respect to how we're conceiving of both housing and economic opportunity. But I understand your point about the specificity in terms of the example that you cited. I'll see if Dr. Easterling wants to add anything, or Dr. Morse.
Thank you, Commissioner. It is a very valid point, and certainly land use planning, and also just thinking about the cumulative effect of detrimental impacts on neighborhood outcomes has been part of certainly the way in which we've been thinking about our data use. I think this specific proposed action, to the Commissioner's point, does include some of the thinking through Executive Order Number 405. It does really think about how we standardize some of the equity metrics across city agencies. We certainly work with Housing Preservation and Development to really think about how we can inform neighborhood planning. I've certainly been a part of some of those planning processes, specifically in Brownsville and Ocean Hill. And we've also been part of conversations for the Jerome Avenue planning process as well. And I think that there are certainly ways in which we can continue to move upon that work. But I do think the sentiment is captured. And I think as we continue to work with the board, how we begin to build out these specific actions, we will certainly continue to do that in concert with the board.
Thank you.
Thank you again, Dr. Klitzman. I'll turn to Dr. Caro now for any comments or questions you would like to pose.
I just congratulate the team, both Dr. Easterling and Dr. Morse, for the hard work. I only have a brief intervention, which is in the seventh introduction, number 7, about the reduce in the jail population in New York City, affecting mostly Black community and Latinos. That data is coming from where? Because it's not clear in my mind. Just that question.
Thank you, Dr. Caro, for the question. Would Dr. Easterling or Dr. Morse, whoever wishes to take that?
Certainly. I just want to make sure I heard the question correctly. The question was, where's the data coming from?
Yes.
Okay. There are several sources of data, and I think the work that our division of epidemiology have really done here is really progressive. And sort of we certainly have a lot of data at our disposal, but this is why we certainly want to continue to partner with our sister city agencies to improve upon how we are reporting mortality and morbidity. And so we already have a really strong relationship with other agencies to really think about how we can continue to receive data. And I think that's the way in which we're thinking about how we be more robust. So not only just through city agencies, we do also work with the medical examiner's office. We also have resources and sources from media, and I think using the multiple sources of data really allows us to really paint a clear picture of how this really impacts the inequities that we know exist around the criminal legal system. And so this is what we continue to want to build on.
And Dr. Caro, just to add a little bit in terms of the specifics of what I believe you were asking about for that seventh whereas clause. The citation is to the 2021 Mayor's Management Report, which does include specific data from the Department of Corrections as well.
Thank you.
Okay, thank you very much. I will next turn to Dr. Kwan.
Thank you everyone for this opportunity. I want to thank Drs. Easterling and Morse for this really comprehensive presentation. There's been a lot of deep thinking and was really taken by the depth by which the whereas clauses go in. I wanted to point out that one of the clauses was about the role of community-based organizations and partnerships in advancing the role of and work towards racial justice. And in the resolutions, 2 and 4, about, resolution 2 is about improving the reporting of race and ethnicity data, and 4 is establishing a data for equity internal working group. I think that we would really benefit from also seeing a role or language around community partners and community organizations that have been doing the deep work, and how we can also establish a direct linkage, a community stakeholder working group to help to also expand and think about how we do the work of reporting on racial ethnic data and collecting that information and developing a data for equity working group and putting that into operation.
Thank you, Dr. Kwan. That's a really thoughtful comment. I'll just start briefly, and then I'll turn it first to Dr. Morse and then to Dr. Easterling. But it's a great point. There are different aspects of community partnership, of community engagement, where I think your comment can help us think more deeply about how to incorporate the ways in which data is collected and shared, in those areas of practice for the purposes of advancing racial equity. The one example that comes to mind that's very tangible is we have a chance to do this through our public health core, which of course, builds upon the infrastructure that we've built with community-based organizations during COVID-19. And I know that that's something that Dr. Morse is actively thinking about. So I'll turn it to you first, Michelle, and then to Torian.
Yeah, thank you again, Commissioner, and thank you, Dr. Kwan, for that excellent question. I'm just going to build on what the Commissioner mentioned, because a big part of the way that we partner with community-based organizations is working with them to identify the areas where they want to expand their capacity, actually. And part of that is in data collection. And so there is a lot of partnership around both understanding what data they would find most useful for us to be reporting on regularly, in addition, working with them to expand their data infrastructure as community-based organizations and their ownership of their own data as well. As a part of that. So I would say that to your point about making sure that the data for equity working group's work is community informed and grounded in community needs. It's certainly part of our approach to date, but we are very excited to continue to deepen that and expand on it, both through Public Health Corps and what you all will be holding us accountable to do if this resolution passes. So really appreciate you raising it.
Thank you again, Dr. Kwan. Sorry, Dr. Easterling, did you want to add anything?
I would just add specifically to the action number 4, particularly around our Data for Equity work group. And I think, as Dr. Kwan already knows, we do have an internal working group that we are now making more permanent. And then some of the work that we've already done, particularly around data, and only using our community health profiles in an intentional way, bringing that into community, but really also thinking about some of the agency's reports and really how we disaggregate, thinking about our Latino report. And also, as you already know, Dr. Kwan, also thinking about how we think about Asians in New York and really making sure that that data as well is disaggregated and really reflects the city. And I think it's important that we continue to hold ourselves accountable, but really formalize that partnership as you're alluding to. And so we certainly want to make sure that we're in concert with the board on that.
Thank you again. I'll turn to Dr. Mitch Katz. Any comments or questions that you'd like to pose, Mitch?
Well, like everyone, I want to thank you for this resolution, which I think is terrific and I fully support. And I look forward, as your sister agency, to working with you to implement it. Thank you.
Thank you so much. I'll turn to Ms. Breyer, Pam Breyer.
Thank you very much, Dave. I think if it's all right with you, I'm really listening to all the comments that my colleagues make, which are smart and varied. And I think if I could wait a little while to comment, that would be great.
Certainly. Dr. Lynn Richardson.
Thank you, Commissioner. I also want to really thank Dr. Easterling and Morse and everybody who was involved in putting together this thoughtful and comprehensive resolution. And I also, like some of my other colleagues, want to acknowledge and thank the agency really for decades of cutting edge work in the area of equity. And I'm very pleased to see this coming in this form to the board at this time. And I have an appreciation for all of the things that have triggered this. But I do have a couple of very actually specific amendments that I would like to offer up to this, as well as a couple of questions. So first, if we start with the whereases, I wondered about the inclusion of the reference to vaccination rates in the third whereas. It did not seem to be in keeping with the arguments that were being made in the whereases. And it seemed a little bit out of place to me. And so I wondered what the rationale was for including it here. I'm not disputing the accuracy of the statement, but wondering why it belongs in this place in this document.
Dr. Richardson, can you say a little bit more to make sure that
it reads that, again, it talks about that BIPOC New Yorkers have been disproportionately affected by COVID-19 infection and death, and then goes on to say, and Black and Latino New Yorkers have disproportionately low rates of COVID-19 vaccination. And it just struck me as a little incongruous as to, because the rest seemed to be a statement about the ways that COVID was impacting on BIPOC New Yorkers, and then there seems to be something about the behavior of BIPOC New Yorkers might be less than exemplary in the way that's phrased. So I'm wondering why that was included here.
I understand your point. And I can speak a little bit to the intention, which was to carry forward, the disproportionate toll of COVID-19 on people of color, on communities of color, and the fact that the lower rates of COVID-19 vaccination would continue that. And so that's why they were tied together. But I do understand your point about couching it in a way that is less structural and perhaps more behavioral. And so I wonder if Dr. Easterling or Dr. Morse have anything to say about that.
I think it's a valid point, and as the commissioner mentioned, certainly our sentiments was really to capture the toll. But if there is a way that we can shift and talk more about sort of the structural impact, and we do want to lift that up, and I think that was also how we grounded our vaccine equity action plan as well. So we can certainly draw the connection.
Yeah, I wonder if we couldn't rephrase it to make it, to sort of take ownership of the fact that we have not been able to achieve equitable vaccination as opposed to something that the groups did to themselves. So that's what was jarring for me.
Yep.
So maybe we could sort of reframe it. And then I wanted to follow up on actually Dr. Caro's comments about the 1, 2, 3, 4, I guess this is the 6th bullet. Again, it just seemed out of place in the whole flow of this document, whereas New York City's investments have reduced the jail population and reformed law enforcement practices in communities. Without debating the veracity of that statement, I'm wondering how it contributes to the flow of this document. It seems.
You want to speak to that one, Dr.
I don't know. It just seems out of place. Maybe it's just an acknowledgement to the administration that they've been doing something, but it doesn't really seem to fit in with the stepwise case that the resolution is making about the role of racism as a public health crisis.
Yeah, no, it's a really good point. I think how we were trying to capture it, because as you'll see in the document, there are points where we want to acknowledge certainly how structural and systemic racism has shown up, and the ways that people interface with these systems. I think it's also important that we wanted to acknowledge some of the work that has been done that we can build on that work during this administration. And so not only just talking about the work around harmful law enforcement practices, but also Take Care New York, and then also our race and justice work. And so we tried to order it in a way that we sort of speak globally, and then try to pinpoint to some of the work that's happening locally. But if it's more of an order in sort of how we sort of frame this, I think, we welcome the feedback. But that was actually the thinking, zoom out and then really also have more of a local picture.
Yes, but if we're painting a picture of how racism has disparately and deleteriously affected certain populations, this sounds more like a commercial for the administration. And it just seems out of place here.
I do understand.
Not disputing its accuracy, but having a little bit trouble including it in this resolution.
I hear your point, Dr. Richardson. I think it's very important for us to address. The one thing I would say to build on what Dr. Easterling has said is that one of the elements that we feel most strongly about is that is that notion of moving from a declaration to a resolution. And part of our intent is to paint the picture of the actions that do need to be taken, and root them in some of the actions that have started. And so, beyond the whereas clause that you're pointing out, you'll see in the whereas clause at the top of page 2, There are also, ways in which we have acknowledged the work that has happened over the last few years, which we felt strongly about including for the same reason, to say that yes, the work certainly continues, but there are significant steps that have been taken that we have to build upon.
Yes, thank you for pointing that out, Commissioner. And I agree that the very specific things that are called out in some of the whereases on the second page do seem to me to be in keeping and appropriately included in the resolution. This one seems somewhat more general and vague, as I say. And I do think that it may even be contestable. And so I would really hate to mar an otherwise, exemplary document with something which, people might seize upon to criticize. So I am a little bit worried about including that whereas and wonder if you would consider either rewording it or eliminating it. And then just to go to the actual resolution itself, which, and again, I think these are very well thought out, but in bullet number 2 under the resolved, this is so key, improving the reporting of race and ethnicity data. I would suggest that we specifically revise this to read during and after COVID-19. I would hate for this emphasis on accurate data to not outlive the pandemic itself. And while I know the pandemic was a key driver of this, the need to have accurate reporting of race and ethnicity data really will continue beyond the epidemic. So I hope that the authors will accept that as a friendly amendment, that it would be during and after COVID-19 in bullet number 2. I don't know if they want to comment on that.
Understood. I've written it down. Thank you.
Yeah. And then in number 4, and again, building on some of Dr. Kwan's comments, I'm very aware of all of the important data resources that the department is responsible for. And, I've watched the growth of the extent to which the department makes data accessible outside of the department over the decades. And I know there are a couple of colleagues on the board who've been here as long as I have who will recall this. And so not only would I encourage explicit reference to community partners, but also to academic partners. I don't want there to be a closing up of data, which I think some of that has happened during COVID-19 for very understandable reasons, but that keyword, an internal working group that talks about data that's available to the health department, as opposed to data that's available to the health department, which it then makes available to community partners and to academic partners who are also interested in anti-racism work.
Thanks, Dr. Richardson, for that point as well. Let me start on this one, and I hope that we may be able to address this one without any changes to the language. And here's my response as to why. The idea is just as you said, the health department provides data for the public, not just community partners, not just academic partners, but for the public at large as well. And our intent in writing this section as we did is to describe that in the first part where it says it ensures that the health department applies this lens to public health data. And so that I think evokes the spirit of what you're getting at, which is to ensure that the data is broadly accessible and available. And then the second part has to do with what is made available to the health department, but rests on the idea that the health department is charged with making public health data broadly available. Does that make sense? My concern in starting to add community and academic is that we may unwittingly actually narrow the remit of with whom we are responsible for sharing data.
I completely understand your point, Dr. Chakshi. I'm fine with leaving the wording as it is, but I guess I just want to make sure that the department understands that while all of the data is made public at the aggregate level, to do the work in communities and certainly to pursue some of the problems that various academics like myself are trying to address, we need data at a more granular level than what's the aggregate level that's available publicly on the website, and that I would hope the department would see the sharing of that data in appropriate ways with appropriate partners as part of its mission.
Thank you. And that is certainly true. But I think that the backstop that we have is in our reporting biannually to the Board of Health, where there is some accountability built in to ensure that this part of what we're aiming to do with respect to data sharing actually meets the point that you're making.
Okay, thank you. I'll stop there.
Thank you so much, Dr. Richardson, for those thoughtful comments. I'll go back to Pam because I see her hand up, and I'm going to try to keep us moving a bit. If we can try to keep our comments to about 2 minutes, if at all possible.
My hand must have been, I don't know, waving and cheering, but come back to me.
Okay. All right. Karen Redlener is next.
Thanks. Thank you very much, Dr. Shoxi, and thank you so much to Drs. Easterling and Morse for this really impressive and powerful work and presentation. I'm very proud to be part of the board that is undertaking this effort to make such a strong and important statement. My comment and question, I have sort of two comments or questions. One is a little bit about pulling out some of the content around children. And the second one is about operationalizing and the structure of reporting, et cetera, going forward. So my work has been, my whole career really has been focused on the impact of poverty and racism on children from a healthcare perspective. And I know sometimes they get forgotten in an approach to look at big issues and tackle systemic problems, partly because they're not so specifically and directly impacted in an obvious way. For example, with the COVID pandemic, we are focused on really understanding the impact of mortality and disease. And for children, the impact of the pandemic, and I know you all know this, but just to make it a little more explicit in this resolution, the impact is often indirect. And they're not becoming sick in the same percentage or as severely ill, but their impact is on losing a parent or a caregiver. Their impact is on losing their educational access for over, potentially over parts of 3 years. So, the impact, it will be potentially lifelong in their foundational stage of development. So I would just encourage those folks who are focusing on, the reporting and the understanding of the various ways that the pandemic is impacting people of color, that you also explicitly add in an element of this impact on children and throughout the various resolutions to think about what is the data that can help make explicit some of those softer, less obvious impacts, but so foundational and so important. Children lose their educational access. The trajectory of their lives certainly is going to be impacted in multiple ways, economically and health and mental health, and et cetera. So that's one recommendation. My second question is really around operationalization of this. And I see that there's a lot of kind of initiatives and centers established, Take Care New York 2020, the Center for Health Equity, the Race to Justice, along with the city administrative initiatives. Is there an organizing umbrella within the Department of Health that pulls all of these efforts together? And are all of these sort of initiatives going to be helping to address the different resolutions for action? I mean, I'm very impressed with the doing something part. I think that's really important, but it is a huge agenda, and to align the activities of the various initiatives or somehow coordinate within, and you may have already thought of all of this, but if it could be a little bit more explicit, potentially, who's responsible, which initiative, or Dr. Easterling, are you the point person for, responsible for the whole thing? And what potentially would be a baseline report. For me, I'm looking forward to the biannual reports on what's happening, but I think it would be helpful for all of us to see where we're starting, or at least, some kind of starting point, and then how we move forward and what the data will show us in the next 6 months, that type of thing.
Thank you, Karen. Those are really thoughtful comments. I'll start on the second one, and I'm sure that that Dr. Easterling and perhaps Dr. Morse will have things to add. But I really want to make sure that we address your point about the so what here, about the action, and about how that will occur and how it's coordinated. I'll say we are striking a balance between making this institutionalized in a way that is somewhat timeless, that speaks to what significant public health issue, crisis that it is, and carries the gravity, of course, that connotes, while also being, as specific as possible in the actions that are described here. And that's part of why we are rooting in the Board of Health, of course, but also these other bodies like the Racial Justice Commission at the city level, rather than getting too operationally detailed, in the language of the resolution. But your point is well taken, and I will say it's one of the reasons that when I became commissioner in August of last year, one of my first actions was to appoint Dr. Easterling as the first Chief Equity Officer of our health department. But importantly, he serves not just as Chief Equity Officer, but also as first Deputy Commissioner, and therefore, along with me, has responsibility for the entire agency. And so from that perspective, both he and I are committed to the actions that are outlined here, and we'll hold ourselves accountable to the board for them. So I'll turn it to Torian if he wants to say a little bit more.
Thank you, Commissioner. Yeah, I think it's a really important question, and we are certainly committed, as the Commissioner has already mentioned, to make sure that we will continue to come back to the board and provide an update. And we certainly plan to do that as early as the end of this year, December 2021. I think it's going to be important to note that we have started to move forward on some of the actions already. And we want to make sure that we provide that update to the board, namely, as I've mentioned, the Racial Justice Commission has already been established. We are already in conversation with the Racial Justice Commission and thinking through what those recommendations will be, and certainly want to update the board on some of the actions that have already been named. So I think this is a really good opportunity for us, in a short time frame, to come back to the board and update. And as already been mentioned, provide that baseline information. But also, as the Commissioner has mentioned, as part of the first deputy and the Chief Equity Officer, the role of really aligning both our internal and external strategy. So rooting how we think about laying out a blueprint for health for the city of New York means grounding it in this declaration. And so certainly the things that I and in this office we look at, really important principles of our anti-racism work is how are we creating an equitable workplace? How are we ensuring that we're fostering accountable and transparent partnerships? Certainly embedding health equity in all of our policies, using our data, and continuing to reframe and shift the narrative so that we are continuing to uplift the injustice. I think this is the work of the agency. And we certainly did not start with me and has been part of this work for during this administration. And so certainly this is the way that we're going to both build it into the operational framework of this agency, while also being clear about the actions that we're taking in the declaration.
Thank you. I mean, it is a huge agenda, and I support every effort that you are making, and I'm very proud.
Thank you again, Karen. And on your first point, we have very much heard and appreciate your ensuring that there is a focus on our children, on New York City's children, as part of all of these efforts. I'll just say by way of comment on it that racism as a system has intergenerational effects, and therefore part of anti-racist practice has to account for that intergenerational transmission. So your point is well taken.
Thank you.
Okay.
Hey, Dave.
Pam, did you have a comment?
Yeah. No, I think I'm, oh, wait. Oh, yes. I think I'm actually ready to comment if I could.
Yes, please.
Yeah. So first, I think I know you will probably want to do the same but before you're done, but I think the one person whose name hasn't been mentioned, who's played a really big role in this, is our counsel, Lisa Landau, who did Herculean work in the beginning with this group, who Torian identified, which was not such an easy thing to do. But to Torian's last point, which I think is so fundamental, and to the issue that you talked about, Dave, for those of us who are as old as I am and have been on the board a long time and worked in public health forever, it is disheartening to look back at proud moments in the history of public health where essential issues were identified, not in the mainstream at the time, and then as quickly as they were adopted and special projects were enacted, they were gone. One example would be what happened in the aftermath of the war on poverty, where many doctors talked eloquently about how food was important to the healthcare of people as their medicine. And sure enough, by a year later, not a year, maybe 5 years later, those programs were gone, mostly, not all, but it was no longer part of the fabric of the way we think about public health. And so I could give you other examples, but in the interest of brevity, I won't. Even some of the things that we have talked about, not on the board necessarily, but in the last year and a half, are not new issues. I mean, none of this is new, and it certainly predates all of us put together. But what I like about this resolution, and why I am so proud and heartened by it, is precisely that it is embedded in the fabric of the rest of the healthcare system, and what this department must do, not as a separate issue, because it's not a separate issue. It is integral. You can't talk about healthcare without talking about inequity. You just can't. So the fact that it is embedded so inextricably into this does give me a sense of confidence that we won't have to reinvent this resolution, or our successors will not have to reinvent these issues as fundamental. I will just add that it is not always a day at the beach to deal with the fierce advocates some of whose names Torian just mentioned. I think this is a great outcome of their efforts, and so in the spirit of what they were trying to do with their petition in the first place. So I want to commend you and Torian and Michelle and Lisa and all the other people who worked on this. It is a very heartening day for me.
Thank you so much, Pam, for that comment, and particularly for that historical perspective. That was extraordinarily well articulated. Thank you. I'm going to try to keep us moving and hopefully get to a vote before too long. We have 2 more board members to go for a brief comment or question. And we'll start with Dr. Sidney Hankerson.
So I'll keep my comments brief. I just, again, want to echo just the remarkable job that Dr. Easterling and Dr. Morse and their staffs did on this document. It's comprehensive, it's thorough, and it's really transformational. My comment is about point 3 in the resolutions. It really stood out to me as really an effort to build trust with communities, which I really commend, and just building upon I think Dr. Kwan's points about 2 and 4 about the importance of engaging communities. I would just impress it upon this board to make sure that that process is equally, if not more so, community informed, because I think agencies' tendencies or our unconscious bias may be to report, but we cherry pick those things that we want to report. And I think it's important that communities tell us what to report in that resolution process. That was it.
Thank you very much, Dr. Hankerson. That's a really thoughtful comment as well. And as you point out, it connects with comments that have been made with by other board members. And I think one of the themes that's emerging, particularly for when we bring back updates to the board, is how much that community accountability has been delivered on or not. And we embrace the board serving in that role to ensure that we are delivering on that commitment. Last, I will turn to Dr. Foreman, last but certainly not least.
Thank you, Dr. Chakshi. I won't repeat all of the very wise and eloquent comments that board members have made, but I will say thank you to Dr. Easterling and Dr. Morse. It is really quite an impressive accomplishment to put together this resolution. I guess I'll just reflect 2 things. Throughout the discussions and the suggestions, which I support all of them, and I thank Karen, by the way, for speaking up for children here as a pediatrician on the board. I see 2 real important themes, and I think I mentioned this way back when we had the original document, which is how critical community partnerships are at every level in this, and how important accountability is, and I mean accountability for the board. And they are hand in hand. So the importance of including community partners at every step of the way will ensure that the board can be held accountable. I am thrilled that there are so many parts of this that will do that, including the reporting to the board, and it then rests on the board to be truly critical and to hold the department accountable for what it does and maybe does not do. So that's really all. I'm really thrilled that at least in part of this item 7 of the resolution, community partners are highlighted. I would agree with Dr. Klitzman and Dr. Kwan's suggestion that it be even more prominent, but it would not prevent me from voting to support this. But the message that those 2 things are so important is what I'd like to convey. And thank you. It's been a privilege.
Thank you so much, Dr. Foreman. Well, thank you all for those just profound comments and reflections. I have the task of trying to summarize and move us forward. So let me try to do that as succinctly as I can. I heard 3 proposed changes to the language, which I'll walk through, and then 3 major themes for us to take back and for us to make sure are incorporated as we consider this, an active document to work on and bring back before the board in terms of the ongoing work. So the three changes that I've heard are first in the third whereas clause to change the last mention of disproportionately to inequitably. This was Dr. Richardson's point to try to emphasize this as a structural factor, which I think inequity does, rather than something that would assign blame or behavioral factors. So that's how I would propose to address that one. And then the other two language changes are in the resolution language. So scrolling all the way to the bottom part of the document, in number 2, rather than just during COVID-19, we would change to during and after COVID-19. Also a suggestion from Dr. Richardson, which I think really speaks to the longitudinality that we're trying to get at with this document. And then the third change is in number 8 in the resolutions, which would add land use between housing and economic opportunities. This is to get to Dr. Klitzman's point, to make it more explicit of the various categories of interventions that we have as part of this. So those are the three changes to language. The three themes, actually, Dr. Foreman did a great job in summarizing them, but I'll just recap. Number 1, we heard from multiple board members about how critical community partnerships are and how they need to underpin really, all of the actions in the resolution. The second was Karen's point, with which Dr. Foreman echoed, which is a focus on children as a linchpin of understanding how we're addressing racism as an intergenerational set of issues as well. And then the third theme was around board accountability, really the board holding the department accountable, and I think is where we can marshal the idea that this is a living document. This is something where we put a stake in the ground with the vote today, but we'll have these touch points going forward to make the institutionalization of our commitment to addressing racism real. So let me see if anyone has other points that they feel strongly about considering. Otherwise, I will call for a motion, but let me take a pause there.
I'd just like to thank you for those amendments, Dr. Chakshi. I appreciate it.
Of course.
Thank you.
Right. I also thank you for the amendments and just ask you to consider, in addition to land use, citing, that's SITING, and cumulative impacts as well. Thank you.
Of course. Maybe we can work it in by saying this: transportation, education, housing, comma, land use and siting, comma, economic opportunities, etc. If that works for you. I do understand the point about cumulative impacts, but I think it probably holds for multiple of those determinants of health. So, I'll propose to leave the language there.
Yeah, I just think somewhere cumulative was a more general comment, that somewhere the cumulative impacts, especially on people of color, needs to be acknowledged. Just not one thing, it's all of it together, and intergenerationally as well.
All right, I hear the point. I'm struggling to think about exactly how we might weave it in with language. So I'll see if my smarter colleagues have any suggestions for me.
I guess one thought, if we want to just name the cumulative impact, we are talking about mitigating harm. Do we want to just name the cumulative impact that we also, as part of the harm that we need to mitigate. We just wanted. Can you hear me?
Yeah, we can hear you.
Okay, I'm getting some feedback. I'm sorry about that. Yeah, so that would be just keeping with number 8, because it's about including cumulative impact, as well as also making sure that we have land use. Does that get you?
I think that's good. Let me just build upon that. So here's the language change. So we'll include housing, comma, land use and siting, comma, economic opportunities. So that's one amendment to number 8. And then make recommendations to mitigate harm due to the cumulative impacts of these determinants within a public health context. Does that work for you, Susan?
Yes, thank you.
Okay.
Great.
Okay, great, thanks. It's always a little bit hard to edit a document together in a board, much less do it via Zoom. So thanks for bearing with us.
Dave?
Thank you.
Yes.
Dave, my only concern here, and I think these are very important issues, is related to timing. Obviously it is mid-October and there is a limited time left in this administration's term. So I guess I just want your assurance that you don't think, all things being equal, that it will cause undue delay in adopting this. Or if we could adopt it as amended prospectively, that would
Yes,
be good too.
that's my intention. With the amendments that we've discussed, we'll call for a vote now.
So moved.
Second.
Okay, thank you. Do I have a second?
Second.
Wonderful. Okay, and now I'll call each member's name for a formal vote. And I apologize, I didn't hear who gave the motion or the second, so I'll go through everyone. Dr. Foreman.
Aye.
Dr. Hankerson.
Aye.
Ms. Redlener.
Aye.
Dr. Richardson.
Aye.
Ms. Breyer.
Aye.
Dr. Katz.
Yes.
Dr. Kwan.
Aye.
Dr. Caro.
Aye.
And Dr. Klitzman.
Aye.
Okay, with a unanimous vote, I am pleased to say that the motion carries, and we have now adopted the resolution on racism as a public health crisis as amended. Okay, we have one more item on our agenda, which is the order of the commissioner regarding vaccination mandates for DOE employees, contractors, visitors, and others. And for this, I will turn it to Lisa Landau, General Counsel for the New York City Department of Health and Mental Hygiene.
Thank you, Commissioner. I am happy to see everybody today, and it is a little anticlimactic, I have to say, to be the last to speak here on something that's a little bit, it's a little bit formulaic in that we're really here. And next slide, please, to extend out officially a particular deadline for showing vaccination. So I think for Department of Education staff and others working in DOE buildings. And so as folks I'm sure remember, it was just on September 17th when the board ratified this very important vaccination mandate requiring that DOE employees provide proof of vaccination. And at that moment, the deadline was September 27th. Next slide, please. But in the interim, a few lawsuits appeared and there was back and forth, and at least one court actually stopped the mandate from going forward for a few days and until the Second Circuit put the mandate back into place. And so it seemed just fair to extend out the deadline by a few days. And we did so, providing that We needed proof of vaccination by October 1st for employees and those working in DOE buildings. And also that visitors would, that proof of vaccination would be required for visitors as of October 4th. We are asking that the board ratify this extension of deadline, really, the commissioner order dated September 28th.
Thank you so much, Lisa. So at this time, we will take questions from the board. We'll do this the old-fashioned way. If you have a question, please raise your hand virtually or on the screen.
I move to approve.
Second.
Thank you, Dr. Foreman. Thank you, Pam. I'll take a vote from each of the other members then. Dr. Sidney Hankerson.
Aye.
Karen Redliner.
Aye.
Dr. Richardson.
Aye.
Dr. Katz.
Yes.
Dr. Kwan.
Aye.
Dr. Caro.
Aye.
And Dr. Klitzman.
Aye.
Thank you so much. Again, with a unanimous vote, the motion carries. I will offer just a brief closing since I know we're already over time. First, I want to thank you all as we continue to navigate this crisis together, the COVID-19 pandemic. As always, I want to acknowledge what each of you are doing, not just as board members, but in your individual lives to help us in terms of our COVID response. And I think that the step that we have taken today with our resolution is emblematic of what we will have to face together over the coming months as well. In starting to take stock of all of those indirect, reverberating impacts of COVID-19 that so many of us have felt in our lives, but which we have this remarkable opportunity to finally change and to restructure and to do things differently. So I'm so proud to be your chair and a Board of Health member today, and I'm grateful to be able to work with all of you. Thank you.
Thank you so much.
Okay. I assume we're adjourned.
Thank you.
Thanks, everyone.
We are adjourned. Thank you.
Thank you.
Thank you.
Great
Everyone.
work.
Thank
Thank you all.
Thank you all.
Bye-bye.